Okay, we meet again here in the studio with Dr. Lee. Yeah, it's a very interesting case. Demonstrate this morning that cover out how we use OCT and then MLD max that shown all in this case this morning. So furthermore, maybe Dr. Lee will give a lecture, interesting lecture to enhance our knowledge about the FFR and OCT. Maybe Dr. Lee, please, time is yours.
Okay, first, good morning again to everybody. Apologize for looking a little bit disheveled. So we had many exciting moments from the first live case in the lab. But as we spoke about earlier in the morning, Benny, I think this is a great demonstration. And this is oftentimes routinely the case that we encounter. What appears to be simple angiographically will not be necessarily the case. And one can actually imagine if we were to miss the nodule and this is not something that is seen, then potentially the overall results would not have been as good as with imaging. So I think now we will move on into the lecture. There has been a lot of discussion about OCT in imaging, and I've also presented some segments during ECCAM recently, 2 days ago. So some of you might have already heard the lecture. So what I've decided to do is to, in essence, move more towards a physiology, because I oftentimes feel that it is a package. So physiology and imaging is oftentimes a package. It most often should not actually stand alone, and it oftentimes will be used together in a symbiotic fashion for optimization of patient outcomes. So maybe we can go to the slides now. Okay, so the topic for today is in essence using coronary physiology with FFR and RFR in the management of multivessel CAD in both acute coronary syndrome as well as chronic coronary syndrome. And these are my disclosures. So let's move into intracoronary physiology to begin with, by means of looking at the FFR for a start. This was what I was alluding to. Visual versus functional assessment is oftentimes very different. I think the mismatches that you can see on screen, whether it is a mismatch or it's a reverse mismatch, is in essence happening with a high degree, either for left main or even non-left main lesions. So in the FAME study, one can clearly see on screen in that if a patient were to have a stenosis of 71 to 90%, there is actually still a 20% chance that the lesion may not be functionally significant, although the classical definition for severity is 70% and above. So I think this really goes a long way to show that physiology is really, really important, as what the trials have actually shown. And a 2-year follow-up of FAME, you're able to clearly note on screen that the overall number of stents were actually lesser, and this would actually impact very much towards the ultimate risk of stent failure, because we should, after all, try to minimize the overall complexity of the procedure by implanting less stents rather than more. And more importantly, there was also a discussion earlier on, Benny, today with regard to the cost effectiveness. I think it has been very clearly shown that the overall cost effectiveness with regard to the utility of FFR was in fact much better as compared to angiography alone. And this was clearly driven by the fact that lesser number of stents were implanted. But I think apart from cost, it is really about optimization of long-term patient outcomes. So the predictors of ISR are plenty, but you are able to note on screen that if you treat multiple lesions, the more stents you implant, the overall risk of ISR actually increases. And with regard to the risk of stent thrombosis, whether it is early or late or very late, you're able to note on screen that the more stents you implant, the overall risk of stent thrombosis is actually higher. And of course, you've got other procedural level characteristics, such as ones that you see on screen, dissection, under expansion malapposition, which all have actually been demonstrated in our first live case, which is why I felt that it was an extremely educational case for the learning of everybody with regards to optimization of PCI using the OCT. One assesses the overall thrombotic risk, bleeding risk, and strategies to reduce bleeding. By and large, we are addressing this sort of patients very regularly on our day-to-day practice. Multivessel stenting would confer them at a higher thrombotic risk. But if a patient is having a high bleeding rate based on the factors that you see on screen, I think it's then imperative for us to try and minimize the number of stents so as to not run into trouble, because the more stents you implant, it becomes more complex, and the mandatory need to actually be on a period of antiplatelet therapy, the stipulated duration of antiplatelet therapy in terms of dual antiplatelet therapy is much longer. And therefore, I think by means of reducing the overall number of multi-vessel stenting, this is going to help the patient very much in the long term. So, so this would actually be the endpoint at 2 years. You're able to see that there was a clear reduction in terms of death or MI. And very importantly, it really is a fine line. I think if you were to intervene at a threshold that is actually lower, then it really does become more of a problem as opposed to conferring any forms of benefits with regard to the utility of FFR. Now, this is a specific subset with regard to its utility in ACS. I think there has oftentimes been a conundrum as to whether this should or should not be done in the setting of an ACS. And by and large, I think if a patient has non-ST segment elevation ACS, it can be safely done even for culprit and non-culprit vessels. But the real issue here is what happens after STEMI. So after a STEMI, if there is presence of microvascular obstruction, as you can see at the bottom of your screen, initially FFR tends to be normal, but eventually after a period of 6 months or so, the FFR tends to become abnormal. So this is something that one should really be aware of at the beginning, because the overall rate of increment or the overall increased IMR at the beginning would actually lead to a somewhat different picture because of an obstruction in the microvasculature. And therefore, by and large, for contemporary PCI, we do not perform FFR for the culprit vessel, but can we actually perform FFR for the non-culprit vessel during a STEMI? The answer is yes, we can. In the Dynamic 3 Primality trial, where the stage PCI was done at the median duration of 2 days, for non-culprit vessels, it was actually proven to be much better compared to an infarct-related artery-only PCI. And we know that the 3-year outcome of the COMPARE-Acute trial has revealed that FFR-guided PCI of the non-culprit artery during the index procedure itself was also associated with better outcomes. So this is something that we can clearly do. But of course, residual FFR, if left being untreated, if they were higher at the beginning, I think it would most definitely be better. Understandably, if it's lower, then it is not going to confer that good of an outcomes. Now, in 2022, of course, we are having lots of non-hyperemic pressure ratios available to all of us. And this is what you see on screen. This is by no means an exhaustive list, but you have got the RFR, which measures the whole cycle, and you have got the IFR, which measures at a specific diastolic component of the cardiac cycle. And of course, you have also got angiography-derived FFR and CT-derived FFRs as well. Now, by and large, this is what the RFR is. I think it correlates very well with the FFR. It measures the lowest filtered PDPA at any point in time in the cardiac cycle. It has also been shown to correlate very well with the other forms of indices that you see on screen, the other forms of non-hyperemic pressure ratios. But technically, there is actually a difference, because the RFR measures the lowest PDPA during the entire cardiac cycle, whilst the IFR measures the average PDPA only during the wave-free period in diastole. So we know that the change can sometimes be, or rather the overall measurement can actually not necessarily be the lowest during the wave-free period, as you can see in this demonstrative case that I've actually illustrated from the literature, in that the IFR in this particular case for the ostial RCA stenosis with a measurement of QCA of 59.6% in terms of stenosis was 0.9 in a wave-free period, but the RFR was significant. And therefore, the operators proceeded to perform an FFR, and it turned out to be significant, and this lesion needed to be fixed. If you were to have based the assessment purely on the IFR, then this lesion would have been deferred, and that is actually going to cause some problems, because this lesion was functionally significant by means of the FFR. Now, are we worried about discordance? The more we do non-hyperemic pressure ratios, the more we would encounter discordance. There are multiple reasons as to why this happens. First and foremost, the location, the presence of diabetes, and gender, and whether this lesion is actually focal or diffuse, the impact of kidney function. Although there are multiple different reasons as to why discordance happens, we know that the vessel-oriented composite outcomes at 5 years did not actually differ very much for lesions that were discordant, and therefore I think at present moment in time, it really is something that we should be taking note of. But by and large, for me personally, I would always rely on the FFR as a hyperemic ratio for the purpose of decision making, as well as for the tiebreaker in decisions whereby it can go either way because of the initial discordance. And therefore, given the fact that there are presence of discordances, technically based on the RECOPA trial, there are also algorithms like this to identify a gray zone of the RFR. If the RFR is between 0.86 to 92, then one should actually use the FFR as a tiebreaker to decide whether you should or should not intervene. Whilst if it's less than 0.86, then it's clearly something that you should intervene. Or if it's something that is a lesion has an RFR of more than 0.92, then you can clearly safely defer any form of PCI for the lesion. Now I'll move into the next phase. I've got 4 cases to present, but these cases will be presented in essence in a rather quick fashion. I'll just focus directly on the angiogram itself. So in total, the first 2 cases would actually be for chronic coronary syndrome, whilst the 3rd and 4th case would actually be reflective of a case of acute coronary syndrome. So briefly, I wish to explain my setup. So for all of these cases, I routinely perform intracoronary adenosine assessment as opposed to intravenous. And personally, I think from meta-analysis, we know clearly that both forms are equivalent. And I think it's much simpler to perform as well. Intracoronary, so for the left coronary artery, it would be 200 mics of adenosine. Right coronary artery would be 100 mics of adenosine, and that is by means of the FFR. But prior to the measurement of the FFR, my routine practice is to first measure the RFR to see what the RFR is, and then I would proceed into the FFR assessment, and all of these would actually be shown during the case presentation. So this is the first case. I think we could all agree that based on the angiogram, you're able to note that there were borderline lesions seen in the RCA. And likewise for the LAD, there were also lesions seen, not very significant, I must admit, at the mid-LAD, but there was actually a rather high-grade stenosis at the ostium of the first diagonal. I will show you some still images later on. There were also disease seen at the distal circumflex, as well as the ostium of the first obtuse marginal, along with the ramus intermedius artery. So this particular patient presented for chronic coronary syndrome. So this was non-ACS case, of course. This particular PA caudal view, the degree of stenosis of the first obtuse marginal appeared to be worse. But what's interesting is that the findings are exactly what we find routinely in clinical practice. So this patient underwent multi-vessel physiological assessment. So this lesion in the LAD was not functionally significant, despite appearing to be high-grade in nature. This lesion in the diagonal was also not functionally significant. And the lesions in the distal circumflex, as well as the obtuse marginal, despite having a high-grade angiographic stenosis, was also not significant. And of course, the lesion, the tandem lesions in the ramus intermedius artery was also not significant. And clearly, the lesion in the RCA will not be significant as well. So this patient went home without a stent. And I think that this really is a best practice that we should all apply. It boils down to the area of subtended myocardium, as you saw early on. The degree of stenosis was extremely bad angiographically on the ostium of the first obtuse marginal, but the overall area where it supplies in terms of myocardium was actually only very small. The arterial size was actually also rather small, and therefore all of these would come into the overall interplay as to whether these lesions ultimately become significant or not. Let's move into the second case. So this second case, you are able to visualize that there were tandem lesions in the LAD, proximal as well as mid-LAD, and there were also lesions at the ostium of the first and second diagonal, and appeared to be high-grade here as well in the left circumflex artery, whilst the right coronary artery had a borderline lesion at the ostium of the posterolateral branch, which you should be able to see right now. So once again, this patient underwent a multivessel physiological assessment. This was clearly not going to be significant, and the lesion in the circumflex, which I frankly thought would be significant, turned out to be not significant. I mean, here you can see some slight discordance. The RFR was 0.84, but the FFR was 0.82. And therefore, this is also a picture that you oftentimes see as to why it is discordant. If a lesion is focal, oftentimes the FFR tends to be abnormal, whilst the RFR tends to be normal. If it's the other way around, is for diffuse disease, the RFR oftentimes would be abnormal, whilst the FFR would be normal. The lesions in, or rather at the ostium of the first and second diagonal were not significant, but it turned out that the FFR assessment, or rather the physiological assessment for the LAD was significant at both 0.73 and 0.73. So routinely in my practice, if I were to encounter tandem lesions, so what I would usually do is to perform a pullback assessment. So we know from the refined RPG study that the pullback using the RFR is an accepted modality with regard to accuracy, and this is what I did. So I first performed an RFR pullback because the RFR was also abnormal. You can clearly see that the step up was greatest at the proximal LAD rather than the mid LAD. And given the fact that I know that that was the lesion of interest, and I performed the OCT, and we have all seen how to use the MLD max protocol for the first case today. So this lesion had some degree of calcifications, which wasn't too difficult to be fixed, and therefore the proximal LAD was stented, and the post-PCI finding was that the FFR was 0.84. There was, of course, a residual lesion in the mid LAD, but I left it alone. Now, at this particular juncture, the patient did actually complain of having some chest discomfort, and I realized that the ostium of the second diagonal was narrowed compared to when it was first assessed, and I remeasured the FFR in this particular branch, and it turned out to be 0.58. So the utility of FFR is also extremely interesting for the assessment of side branch post-procedure. And this patient needed a bailout kissing balloon inflation, of which the FFR of the second diagonal improved to 0.91, and the procedure was completed with an OCT run, which revealed good stent expansion and good results as well throughout the course of where the PCI was performed. So third case is really a case that I wish to show because this was a case with an acute coronary syndrome. So this patient had a lesion, as you saw, or as you can see right now, in the LAD. And the patient also had a culprit lesion in the RCA, which ultimately was fixed without physiology. I think, Benny, in the morning, there was a question as to when you should and when you should not. But for this sort of lesions, especially that you can see on screen right now for the RCA, clearly this is the culprit based on the ECG. Angiographically, it appears to be very significant. So this lesion was fixed without physiology to begin with. Of course, OCT was used, and this was the result post-PCI of the RCA. Now, I personally felt at that point in time that the LAD potentially may not have been significant, but it turned out to be the case in a different manner, in that the LAD was significant both by means of the RFR as well as the FFR. And once again, pullback was being performed. The step up was clearly at where the area was being the most stenosed, and OCT was performed, relatively straightforward at PCI, and post-PCI procedure was 0.9. Now, the reason I wish to highlight this case is that I wish to introduce a concept of post-PCI FFR, which I think is something that is very important that everybody should assess, and the physiological assessment should not actually stop at the pre-PCI level. As you will see, the next case, the post-PCI FFR can actually be extremely valuable assessment towards optimization of PCI. So the last case for the day would also revolve around a patient with acute coronary syndrome. So clearly you're able to note presence of tandem lesions. Now, for this particular lesion, I had to first assess physiology most definitely as well, because they were also concomitant lesions elsewhere, especially in the circumflex. RCA was relatively okay by means of angiography, so this was not something that I use physiology for, because clearly there were no ambiguous lesions, but I just wanted to know whether this particular branch was significant, and clearly it was not. I think here it's also a good concept to reflect that the size of the obtuse marginum is actually much bigger, and it supplies a much bigger territory compared to the left circumflex, which is why it turned out to be the case of which it is not functionally significant, both by means of the RFR as well as the FFR. But for the LAD, given the fact that there were tandem lesions present, the FFR was clearly significant at 0.47, very ischemic. And I first did a pullback, and it appeared that the step up was greatest at where the tightest lesion appeared to be. I had to pre-dilate, just like what we saw in the first case today, because the OCT clearly would not give you a good enough assessment over here if the stenosis is that bad. Ultimately, after pre-dilatation, so this was what I found, predominantly lipidic, some areas of calcium, as you can see on screen, but generally made up of lipidic plaque as opposed to having a fibrotic content, but they were thankfully healthy landing zones to land approximately as well. After stenting of the first lesion, the FFR improved, but not to the point that I wanted it to be. So it became 0.73. And this is what happens occasionally when you have tandem lesions, when you, in essence, perform a PCI for the first lesion, it oftentimes may potentially unmask the functional severity of the second lesion. So I re-performed the RFR pullback and completed the procedure with a second stent that was overlapped with the first one, and the post-PCI FFR became 0.82. Now, so there have been many questions about what should be ideal and what is not ideal. I think what is ideal and what is not would really depend on how much more you can do. In this particular case, although it was 0.82, as you can see, distally, the disease was rather diffuse. So this is very acceptable in my opinion as to why it became 0.82. So the overall concept of post-PCI FFR is as per what you see on screen. So there have been different targets. Some have actually used 0.86 as to what it should actually be achieved. And some studies have also reported a slight difference in terms of target, depending on whether it is a LAD or non-LAD. But generally, I feel this table is extremely important for everyone to take note of, which would be the causes of suboptimal post-PCI FFR. So it can be a geographic miss, it can be a stent that was actually underexpanded. It could also be due to an H dissection. It could be due to spasm or bridging. So all of these causes would actually have to be factored into play. And I think based on what we've seen today, of course, we did not use physiology for the first case, but if we would have used it and there was actually a post-PCI FFR that was not very satisfactory and the mechanism is unclear, as you can see towards the bottom right of your screen, is to actually use imaging to repeat a pullback and to check throughout the length of PCI or whether distally there would actually be any more residual lesions so that you can better intervene and improve the overall post-PCI assessment. So ladies and gentlemen, in summary, I think I've covered a fair bit on the utility of physiology, in particular FFR as well as RFR being the non-hyperemic pressure ratio. And I think both of these modalities would pair really, really well with the OCT to improve the overall outcomes of patients. And has been clearly demonstrated in the first case, the overall utility can really sometimes be best seen with routine cases. And I don't think we should actually dichotomize to choose a selected subgroup of patients whereby imaging or physiology should be done. I think it really is best practice to perform them routinely because definitively it has been shown to improve patient outcomes. So thank you very much for your kind attention, ladies and gentlemen. And now, of course, it's me and Benny again if you have any questions to ask. Thank you.
Thank you, Dr. Lee. Very interesting and insightful presentation, and you cover almost the comprehensive side of using the FFR and imaging also. And if you have any question for Dr. Lee, maybe you can just put in the Q&A and we will answer that for you. Dr. Lee, you said that, yeah, sometimes we have a discordance during measurement physiology. So in your current practice, which one that more accurate or more reliable? FFR, RFR, DFR, or IFR?
Okay, so by and large, I think the overall discordance rates have been similar throughout the different spectrums of non-hyperemic pressure ratios. So irrespective of whichever that we see, which was why the study that I showed had a combination of a few different non-hyperemic pressure ratios. At the beginning, when I first started to use the non-hyperemic pressure ratio, of course, it created a little bit of confusion as well, because which one would you actually rely on? But at the end of the day, because of the fact that the modality has existed for a much longer period, which would be the FFR, and all forms of non-hyperemic pressure ratios have always been compared to the FFR in terms of the correlation as well as its accuracy. So I would always rely on a hyperemic ratio, which would be FFR in this case, as a tiebreaker. But it's interesting to note, because initially we all wanted to know as well whether a decision that was made driven by certain forms of discordances would impact on patient outcomes, but thankfully it does not. Having said that, I think at present moment in time, it remains a topic of interest academically, but we must all realize that if there is a discordance, we should all try to understand the nature behind the discordance and why it happens. And by and large, one very common reason is, as per what I told you about the case early on, as to the difference between a focal form of disease versus a diffuse form of disease, and this often tends to bring about discordance as well. And the other thing that I wish to mention is also it would depend on which artery we are intervening, whether it's the LED or non-LED. So all of these factors would impact on discordance. I think right now it really is something that all of us must be aware of. But ultimately, for me personally, given the fact that my workhorse physiology method is to always perform both, so I in that sense, I don't really routinely run into trouble by means of just decision making based on either one of it. Because of the nature of the setup, for me, the FFR and the RFR is measured using the same wire. So at the beginning of the procedure, it is always administration of nitrates, assess the RFR, and it can very quickly be then followed by adenosine. So really, I think it adds on potentially about 20 seconds to the overall procedure. So therefore, I do it routinely for all vessels as well.
So for the hyperemic, you use adenosine Intraco.
Correct. So there have been, of course, the question as to whether how safe it is.
Yeah.
I think the whole point of going towards angiography-derived FFR or rather physiological assessment, as well as CT-based in some of the other non-invasive methods, would really be the fact that how safe it would be for the administration of adenosine. I think generally with the dosing of intracoronary of just 200 mics in the left and 100 mics on the right, it is an extremely safe dose. By and large, we have not ran into that much of a trouble. Of course, if one has actually done a lot of physiology intermittently, there will be some arrhythmic issues, which really is not very hard to resolve. There's, of course, the concern about the risk of bronchospasm, etc. But the point is, most of these patients, if they are prepared well pre-procedurally, they are known to have very brittle bronchial asthma or even chronic obstructive pulmonary disease. And by and large, all of these patients would already have been pre-medicated with steroids pre-procedure in my practice, which is why if a good clinical history is taken, all of these pointers are not left out. During the procedure, I think performance of ad hoc physiology using adenosine is something that is very, very safe.
Okay, thank you. So stable. And if we see from your case here, you see with the multiple lesions in the case 2, I see you in the LAD, and you see the more step up is the most significant, right? So you treat only the proximal and then left the distal. After that, we measure again. This is the current practice that we need to.
Correct. So the assessment of tandem lesions would be sometimes there might potentially be a cross-talk between two lesions as to the overall hemodynamics may be impacted by one stenosis and the other. And therefore, the principal way to perform tandem lesion PCI using physiology is always to first look at the biggest step up. So of course, there appeared to be a difference in my second and my fourth case, because after performance of PCI for the second case, the post-PCI FFR was significant, or rather it was normal. So it was acceptable, and I left the other lesion alone. But for the fourth case, I needed to perform an additional stenting, an overlap stent, because the post-PCI FFR was not optimal in that case. But if all of you are able to remember, the pre-PCI FFR, of course, was also much lower for the fourth case as compared to the second case.
Mm.
And therefore, I think this is a common occurrence in clinical practice. To perform tendon lesions, angioplasty, we must be ready to perform a post-PCI FFR, which is why if one just relies on a pullback and completes the procedure without a post-PCI functional assessment, you will never know whether there's residual lesion. You may tend to miss lesions as well. And therefore, post-PCI FFR for me is something that is really important, and it's also easy to do. I must also admit, as part of my workhorse, is that I use the FFR wire. In this particular scenario, the FFR and RFR wire would be the pressure wire X as my workhorse wire. So I don't routinely swap out wires.
So you use that wire?
Correct. So I would do all forms of my PCI over the wire. I would also do my OCT over the pressure wire as well. So I don't swap out the wires. So what I usually do is that I will perform the PCI. Of course, you equalize and you give nitrates and you perform the assessment. And if I need to perform PCI, so that would serve as a workhorse. And all tools, balloons, everything else would actually go over the wire, with the exception, of course, if you need specialized wires for atherectomy and all that. And of course, we would actually swap it out. But other than that, all forms of balloons, all forms of stents, even OCT would oftentimes be performed over the FFR wire. And after I have done all those things and the wire is still in place, and I will just recheck the post-PCI FFR. I don't really need to equalize again. And I'll just pull it back up to make sure that there's no drift. So it really is a one-wire procedure that simplifies the whole procedure, which is why I find it really convenient, actually.
Yeah, interesting. Usually we change the wire to other wire.
Actually, a lot of people may feel that the pressure wire is not really the best wire. It should not be your workhorse. But I think what is workhorse and what is not workhorse is really, as for what Dr. Munawar has mentioned earlier on about him favoring rotational versus orbital atherectomy, it's about how much of a personal experience you've gained, and how you somehow, as classical saying goes, how you're able to be friendly and tame the wire so that the wire really becomes your workhorse. And generally, I think I find the pressure wire X being extremely good in terms of wiring even tortuous lesions, etc. I've never really had much of a trouble. I think really the point here is about getting to know your wire well, and not try and adapt a workhorse from someone else, right? Because of course, when everybody is embarking on PCI, you start off on a program and someone would tell you, your mentor would probably tell you that his or her workhorse is as such, and you tend to follow. But really, one should look for their own workhorse wire.
I think in your second case, you show when there is a pinching and diagonal.
Correct.
On the stand start, you can enter it easily also.
Correct.
Okay.
Correct. So FFR for side branches are also very useful, and oftentimes you can leave your FFR wire in either one of the branch. If you anticipate side branch issues, you can actually leave it at your side branch as well. And of course, you would wire the main branch with a separate wire. And after performance of provisional, you can also immediately check your FFR in the side branch, and then you can swap out the wires. So that's what I usually do. If for provisional, I would usually keep the FFR wire in the side branch so that I can actually immediately check it if it needs be, if there's actually a side branch compromise in the ostium. Especially when I go provisional, I'm not entirely sure whether there would be a plug shift, there'll be a carinal shift. So I think it's really important to have a wire there already. Because if you don't keep the wire at the side branch, then you really need to rewire again. That might be a problem. So
the wire is a gel wire in the
wire is a gel wire. I think one has to be just a little bit careful to know where the position of the sensor is. So it's at where the proximal marker of the tip, the radio opaque is.
To be inside there.
Correct. So it definitely has to be a bit more distal. Thankfully, so far I've never really had issues with jailing the wire. I think in respect to what you've mentioned about the ability to rewire easily, it also serves as a good wire marker. So with a wire in there, on the assumption that you really need to perform PCI, you would need to rewire again because the wire is now under the strut and is jailed. And if you know that the physiology is actually been impacted as a result of your provisional, then you can also use that as a wire marker to keep the wire there. I mean, ultimately, if you really have difficulty, then you can salvage it with some small balloons, just to perform some other maneuvers.
Interesting. So I think everybody is astounding with your presentation. There's no question now. And Okay, for the first case, I think it's very interesting. I see very from angiographic significant lesion, and patient also have a chronic coronary syndrome. You maybe have a chest pain when you have PPP, and in fact, after you do a FFR, all the lesion is non-significant. So how is the patient now? Or you treat it medically only?
Yes. So I think by and large, based on trials of contemporary medical therapy trials, we know that medical therapy, or rather optimal medical therapy, based on guidelines, they do work really well as well. So the patient initially had stable angina, but went for a non-invasive exercise stress test that was rather equivocal. That was why I brought the patient to the lab. So there was actually a non-invasive functional assessment. But as we know, with stress testing, the ability to really locate ischemia in terms of accuracy as compared to having an epicardial assessment is really, really different in terms of the outcomes. And therefore, I think by and large, the ability to avoid stenting here would go a long way in terms of overall long-term outcomes of the patient. We have seen patients these days requiring surgery, requiring elective procedures that have unnecessarily been delayed or postponed because of the fact that they need to complete the duration of dual antiplatelet therapy. And by and large, of course, we have got stents to support the utility of short course DAP these days to keep it at a minimum of a month or so. But frankly, that really is reserved for patients with high bleeding risk. And we don't routinely preach to use just 1 month of dual antiplatelet therapy. We should really stick and conform for proper vessel healing, etc., because that is the bare minimum. And by and large, if a cardiologist or treating cardiologist would want to ensure that healing is better, and he or she would definitely administer dual antiplatelet therapy for longer duration. And this would mean that a lot of procedures or surgery would unnecessarily have to be delayed. Right? And mandatorily, of course, if a patient were to end up having bleeding, unfortunately, during the period whereby dual antiplatelet therapy is mandatory, 2 weeks post-procedure, for example, then he or she would need to be off antiplatelet therapy because there's active bleeding on board. And without antiplatelet therapy on board, you then have a high risk of stent thrombosis as well. So, one can actually imagine that all of these things have really been happening in reality as well, and we have been involved in the management of complex patients like this. More often, it's complex because of the overall decision making rather than the overall complexity at presentation, which is why if a patient does not require a stent, then they don't require a stent.
Yes. Okay, also save the cost of the patient.
Yes, that is very true.
Okay. A bit out of topic. If we see the epicardial lesion is not significant, but patient have symptoms, you mentioned earlier about the IMR. What do you think the IMR in the current practice?
Correct. So that is a space that I think eventually we would all go down into. At present moment in time, thank you very much. Okay, we take note. We just had a queue that there's a 30-minute break for those of you who are wondering what we were what we were looking at. So I think the microvasculature is an extremely interesting space. So through various different methods of assessment of IMR, CFR, I think it would give us a lot more of an understanding, and a lot more academic explanation can be provided to the patient as a reason for their symptoms. We must be aware that the FFR is at present an epicardial assessment. So some patients might still have microvascular disease, etc. And these patients would benefit most from medical therapy, at least, of course, with the utility of purely just an epicardial assessment right now without a proper assessment of the microcirculatory. At best, it's a postulation. But we're slowly getting there. I think adaptation for measurements of the microcirculatory indices are slowly progressing in terms of its overall uptake. So this is, of course, Dr. Benny, you're right. This is an interesting space to look up for, microvasculature.
Okay.